All right, we're live.
Okay, good morning. It is Senate Health and Welfare Committee, and it is April 9th. Today, we're going to look at two bills relating to healthcare affordability and accessibility, working to determine how best to move forward with what some are calling healthcare reform. And so we'll look at S-132 and S-120. And before we begin, I think just to digress for a second, I've been working with Nellie and asked Ruth to put together a spreadsheet along with Nolan on some of the budget requests that we're seeing. And so thank you very much, Ruth. I think Nellie is getting you some information, and information keeps coming in from people requesting either ARPA funds or some base budget improvements. So we're going to put all of those together, and on Tuesday, we'll be able to look at that spreadsheet and the requests that have come in from various parties. Not all of them have been in committee, I want to make that clear, but they are written fairly clearly, and hopefully with our background and the work that we've done in the past on these organizations, both with CRF and more recently, we'll be able to make establish some priorities. So I'm looking to Ruth and working with Nolan. And so we'll try to get that out to everyone before the end of the weekend. Does that make sense, Ruth, or Monday? What's
Yeah, I'll try to get it to you Monday morning.
Okay.
Nolan has sent me a first list, which Nolan I haven't looked at yet, but I will work on it this weekend. If any of you have things that you want to send me also, we'll put it on the list. I'm going to try to color code it or organize it in some way we can go through it easily.
Perfect. Sounds terrific. So then we'll look at, you can bring in what you have on Tuesday and we'll go through it. That'd be great. And Nolan, thank you. This won't be easy. I know that we've got things in the budget, and then we also have requests for one-time money. So sorting out our priorities, our policy priorities is number one. And then where the money comes from will be up to appropriations. But we'll have to see how all that fits together. Okay. So Jen Carby is here with us to go through two bills. The first bill, S-132, let me just explain a little bit about what's in that bill. And I would like to say right from the outset, there's a lot in that bill that is going to be, as we go through the bill, I or you on the committee can make some decisions about the difficulty of evaluating those and including those in any legislation at this time of the session. So I'm happy to discard. There are a number of things that I've already decided we might want to consider discarding. On the other hand, there's the goal for us in making healthcare more accessible and more affordable, as much as possible to align the payer system that we have. So, and when we think about aligning a payer system, then that leads to more uniform access for folks, and also then allows for us to consider how to reduce copays and other premiums that patients right now are experiencing some really a lot of hardship, and healthcare has reached a very high cost. It continues to go up. And then also knowing that some of the reform efforts that we have held back and held down the increase, at least the 3.5% cap, I'll call it a cap, but 3.5 cent budget restraint for hospitals has been effective. And so we want to keep looking at some of those things that are helping keep the reins on costs without harming the system itself. Well, that's one. Another goal that I see and I'm very committed to, which has been a part of the ACO discussion, is the relationship between provider community, medical provider community, and our social service community, and ensuring that we have some continuity of care and that there is some case management going forward that allows for people not to get lost in this system. And again, that comes back to how we align our social services and our healthcare, say medical services together. So there's a lot of thinking that we will want to do, and I know that you all have been thinking about this, and so I'm going to turn it over to Jen to go through S132 and then to go through 120. And our goal today is simply to look at the bills. So, and then we're going to hear from DFR, who's doing some work on the basic benefits is what I always call it, but that's not what it is. Jen, help me.
Benchmark, you can benchmark plan is what they're going to talk about, I think.
Our benchmark plan with respect to hearing aid assistance. So I want to hear from them because that's something we might be able to continue to work on along with DFR and others. So then after we've gone through those two bills, we're going to come back to some primary care issues with the Green Mountain Care Board. And we'll try to take a break in between. So there we are. So Jen, thank you for being here. And we'll look forward to going through those two bills. I know that one is a little more a bumpier road than the other, but let's see where it takes us.
Great, thank you. Good morning, Jennifer Kirby, Legislative Counsel. I will put the bill up on the screen. Okay, hopefully you can see that. This is S132, an act relating to healthcare reform implementation. It has a number of different topics in it, so I tried to use these reader assistance headings just to kind of ground you in what the topic is as we go through. So the first couple of sections are on responsibility for healthcare reform efforts. Section 1 would amend the existing section that creates the position of the Director of Healthcare Reform in the Agency of Administration, which is currently responsible for coordination of healthcare system reform efforts across the executive branch. This would add then a specific requirement that the Director of Healthcare Reform be the one to coordinate and lead all state initiatives relating to healthcare reform, including innovations in healthcare system payment and delivery. Section 2 deals with the all-payer model, the full name of which is the All-Payer Accountable Care Organization model. And this says that upon renewal of the terms of that model agreement, the all-payer model agreement with CMS, the Centers for Medicare and Medicaid Services, the Agency of Human Services would assume responsibility for oversight of state efforts to achieve the agreement targets in the model as set forth in an existing statute, and any similar or successor model, and Agency of Human Services would lead the state's efforts to achieve the agreement targets, the state's renegotiation efforts, and the stakeholder involvement processes. So this is expanding on the role of the Director of Healthcare Reform in the Agency of Human Services and the role of the agency itself in the state's healthcare reform initiatives.
Jen, wait, do you want us to wait till you're all done or interrupt you as you go, which is easier?
Whatever, it's probably easier if you just ask your questions as we go along, because we'll be looking at the language.
Okay.
So go for it.
Who has these responsibilities now?
Right now, a lot of the efforts or responsibilities are split between the Director of Healthcare Reform, the Green Mountain Care Board, those are sort of the main ones. And I think the idea here is to move all of that kind of reform-minded effort under the Director of Healthcare Reform and leave the regulatory duties with the Green Mountain Care Board.
Okay, thanks.
Senator Lyons, I mean, you're the sponsor, so I can
That's
let you speak for
accurate.
yourself as well.
Yeah, no, that's accurate.
So that was the first two sections, and then we move more directly into ACOs.
I'm
Section.
sorry, Jen, before we go
Yes.
on, if I can, Senator Lyons. So can you just clarify the ACO's role here? I mean, if we have the director having authority and the board having authority, then what's the role of the ACO?
The ACO's involvement is really in carrying out the healthcare reform efforts. So the state has designed them. The ACO is playing a role in achieving them, but isn't the one overseeing or it's the one being overseen. It's the one being regulated and participating in the healthcare reform initiatives.
Okay. All right. Thanks.
And then we go on, I mean, the state also regulates ACOs, and we're going to look at some potential changes to those requirements in these next sections. Section 3 amends the existing law where the Green Mountain Care Board is required to certify accountable care organizations and do annual budget review for accountable care organizations. And so the first part of that existing statute is the certification piece. And it requires, under existing law, that in order to certify an ACO to operate in the state, the board must ensure that certain criteria are met. So this is adding to those. There's an existing criteria about the ACO's governance, leadership, and management structure. This would include language that says the salaries for the ACO's executive officers do not exceed an amount equal to the median salary for a primary care physician participating in the ACO. So looking to put some guardrails, some boundaries on the salaries for the executive officers. The next piece adds on to some existing language around coordination with the Blueprint for Health. And this would specify that the ACO coordinates with the Blueprint's patient-centered medical homes and community health teams and acts as the link connecting patients with appropriate health care and social services, including those offered by designated agencies, specialized service agencies, parent-child centers, and schools. Then in another existing provision around the ACO's acceptance and contracting with providers to participate in the ACO, this specifically allows the ACO to contract with a participating provider for a multi-year term. So it doesn't just have to be a one-year contract, it can be a multi-year contract. So those are all in the certification piece. And then in the budget review piece, where existing law directs the board to review and consider certain items, this would add on to the existing provision around information on the ACO's administrative costs. And it would say, including either the annual salaries and benefits for all of the ACO's employees, or the same salary and other compensation information for the ACO's officers, directors, key employees, and other highly compensated employees for the previous calendar year that the ACO provided to the IRS on its Form 990 for the most recent tax year, or that the ACO would have been required to provide on Form 990 if it was exempt from federal income tax. So this is really piggybacking on the existing IRS criteria around what kind of salary and compensation information has to be reported for nonprofit organizations exempt from federal income tax under 26 U.S.C. Section 501. But I think at least currently the one ACO that is certified in the state is not nonprofit under federal income tax laws. So it says report the information like you would if you were tax exempt. And if they are tax exempt, then just provide that same Form 990 information. And then it adds a new budget review piece for the board to review and consider. and that is the extent to which the ACO has met the quality measures specified in its payer contracts. And if one or more of the quality measures has not been met, the ACOs and payers plan to remedy the deficiencies. So that's all in the context of the Green Mountain Care Board's certification and review of ACO budgets. Then this would add a new section, in section 4 would add a new statutory
So
section.
I want to just stop there
Sure.
for a sec, Jen. Is there anything currently that asks the Green Mountain Care Board to evaluate the quality metric analysis that's going on with the ACO?
I'd have to look. I have to say
okay.
I'm not fluent
We'll
enough.
hear from the Green Mountain Care Board
Right.
how they incorporate that, but certainly it's an
I-
important aspect.
I do think there are some I do think there are some provisions in the existing law that require the ACO to have quality measures and to be evaluating them. This is looking more at the
This-
outcomes of that, at the results of that. So then we have a new section around the ACO, the value-based payments and distribution of shared savings, and this creates a role for the Green Mountain Care Board in that. So it says that the Green Mountain Care Board, using the results of an ACO's quality analyses pursuant to a section we're going to see coming up, so a new section. So the Green Mountain Care Board, using the results of the ACO's quality analyses, must establish a methodology for determining the amounts of the value-based payments that the ACO must make to its participating providers for delivering services to its attributed patients. So the board would create a methodology for determining the amounts of the value-based payments, and then the board shall apply its methodology and shall notify health insurers and Vermont Medicaid of the value-based payment amounts based on its determinations in order to inform the insurers' developments of their rates for health insurance rate review, the board does, and to inform Medicaid's development of its all-inclusive population-based payment arrangements that the board reviews in accordance with existing law as well. So this is, just to summarize, this is directing the board to come up with a methodology for determining the amounts of the value-based payments, and then calculating them and telling the insurers and Medicaid what they are, so they can be built into their financial models, their rate reviews, and their all-inclusive population-based payment arrangement.
And currently that value-based payment is determined by the ACO
I think it's between the ACO and the payers.
and the payers, right?
So this would put the board in that role instead. And then it also would have the board, and it's a few words, but it's a big impact, would have the board using, again, the results of the ACO's quality analyses that we'll see in the next section to determine appropriate allocations of shared savings, if any, for distribution among the ACO's participating providers. So this piece is having the board figure out how much, if there's shared savings, how those should be distributed among the ACO's participating providers. And this is something that currently, I believe, is just the ACO that's in this role. Section 5 is a new section that would go in with the ACO, some statutes around the ACO itself. So in a different chapter from the board, because it's really about the ACO. This directs an ACO to collect and analyze clinical data regarding patients' age, health condition or conditions, healthcare services received, and clinical outcomes in order to determine the quality of the care provided to its attributed patients, implement targeted quality improvement measures, and ensure proper care coordination and delivery across the continuum of care. So having the ACO collect and analyze data about what's going on with its attributed lives to determine quality and figure out how to improve things and ensure proper care coordination. And it requires the ACO to provide the results of its quality analyses to the Green Mountain Care Board, so to inform the board's determinations of the amounts of the ACO's value-based payments to participating providers, and to calculate appropriate allocations of shared savings for distribution to the participating providers. So in the previous section of the statute of the bill that we'd looked at, it would create a new some new roles for the Green Mountain Care Board informed by this ACO data collection and analysis. And then here's the flip side of that, directing the ACO to do that data collection and analysis, and provide it to the Green Mountain Care Board.
Jen,
Yes.
isn't paragraph A, aren't they already supposed to be doing something like that? I mean, that seems to be what they say they're doing.
Right. I'm not sure that this is a new role for them, but it's not a statutory requirement. So
Okay.
this is kind of putting it in the statute in part so that that information can be provided to the board, directed to be provided to the board to inform the board's work around the value-based payments and shared savings.
Okay, thanks.
So sure, and I'm sure the ACO could tell you what they're doing in this area currently, but I don't know that it was necessarily intended as a completely new role. All right, and then section 6 is some language that has also appeared in, I think there's a standalone bill that may be either on the wall in this committee or in another committee that would require a certified ACO to make available to the Office of the Auditor of Accounts, or the state auditor, all records of the ACO and any affiliated entity that the auditor, in the auditor's discretion and upon request, determines are needed to enable the auditor's office to audit the ACO's financial statements, receipt and use of federal and state funds, and performance as set forth in the statute creating and setting forth the duties of the state auditor. So this, again, is requiring the ACO to provide all the information to the auditor that the auditor thinks his office needs to audit the ACO and ensure appropriate use of federal and state monies. All right, so then we get into a section on the Green Mountain Care Board's duties, and this is really kind of, I put it here as kind of a bridge section because it incorporates what we just looked at and then what comes next. This adds 2 new duties to the Green Mountain Care Board. The first being to establish the methodology for determining the amounts of an ACO's value-based payments and appropriate allocation of shared savings among the ACO's participating providers. So that was the piece that we looked at. And then in the next section, we'll see this new duty to review and approve proposed fee schedules and healthcare contracts between health plans and healthcare providers. And so here is a new section, which did you want to?
Just on a
sure.
comment on the number of contracts that are there, it's probably what we understand is that they are significant. So I guess the discussion around contracts really goes to model contracts or some kind of evaluation of fewer contracts than all of them. Would be probably unbelievably difficult to do all of them.
Yeah, and I think we'll see as we go through, and you know, you've set up a process for kind of for the board to collect a representative sample and get a sense for what they would be reviewing for. So there may be modifications needed at that point. I will note, as I was sort of looking through the bill, preparing to do the walkthrough this morning, that I appear to have used 9384, section 9384 as a new section twice. It's because the statutes currently go through 9383 here. So this would be something to change going forward. And it does get referred to and cross-references a few times. So apologies for the error and any confusion. But this would add a new section in the Green Mountain Care Board statutes around review of healthcare contracts and fee schedules. It uses some existing definitions in chapter 221, subchapter 2, which is on claims processing and contract standards for health insurance plans. And then it says that a healthcare contract between a health plan or other contracting entity and a healthcare provider shall not be effective until it has been reviewed and approved by the Green Mountain Care Board for fairness and consistency with the provisions of that subchapter on claims processing and contract standards, the board's rules, and other applicable laws. So healthcare contract would not be effective until the board has reviewed and approved it. And similarly, a fee schedule setting forth the amounts that a health plan or other contracting entity shall reimburse a healthcare provider for delivering healthcare services shall not be effective until it has been reviewed and approved by the Green Mountain Care Board for fairness and compliance with the board's rules and other applicable laws. And it directs the board to adopt rules establishing the fee schedule and healthcare contract review processes, including the standards under which the board will review proposed fee schedules and healthcare contracts. So that might be an opportunity to lay out some things that would be appropriate once they determine what they should be reviewing for. Then there's some changes. Section 9 makes some changes to an existing statute on fair contract standards, and this is about contracts between payers and providers. So the changes in here, other than just a grammatical correction, are first to eliminate language allowing contracting entities to require healthcare providers to execute written confidentiality agreements with respect to fee schedule and claim edit information received from contracting entities. And then putting in language requiring contracting entities to provide at least 120 days for a provider to consider a proposed contract and for negotiation of contract terms, including reimbursement amounts. Adding language requiring that healthcare contracts must be for a minimum of 2 years, and that prior to healthcare contract taking effect, it must be reviewed and approved by the Green Mountain Care Board for fairness and consistency with the provisions of the subchapter, the board's rules, and other applicable laws. And then it takes out this language that says that requirements of subdivision B5 of the section do not prohibit a contracting entity from requiring a reasonable confidentiality agreement between the provider and the contracting entity about the terms of the proposed contract. So taking out a couple of provisions around confidentiality. Section 10 requires the Green Mountain Care Board to collect and review a representative sample of healthcare contracts and fee schedules from health insurers, including contracts and fee schedules with hospital affiliated and non-hospital affiliated healthcare providers, in order to inform the board's development of its methodology for reviewing healthcare contracts and fee schedules in accordance with that new section. And on or before January 15th of 2022, the board would provide information to the House Healthcare Committee, this committee, and the Finance Committee regarding the board's proposed methodology for reviewing healthcare contracts and fee schedules, including the standards and criteria that the board intends to use for its reviews. And then it says that confidential business information and trade secrets received from an insurer through those representative sample of contracts would be exempt from public inspection and copying under the Public Records Act and kept confidential, except the board can disclose or release information publicly in summary or aggregate form if doing so would not disclose confidential business information or trade secrets. So they can kind of tell you what seems to be, themes or particular types of sections that are, or provisions that are in the contracts, but without disclosing business secrets. All right, then we're going to turn to a different topic. This is on durable medical equipment.
So let me just say, this is a bill that we've had in committee. I don't know whether we introduced it this year or not. Possibly not.
I don't think so.
But it is a concern. The cost of durable medical equipment continues to be a concern across the board. So unless you're selling it yourself, the providers, the payers, everyone is concerned about these costs. So I've included it here.
This would add a new subchapter in 18 VSA chapter 221, which is on healthcare administration, sort of broadly, on durable medical equipment and cost transparency. So it starts out with a definition of durable medical equipment, which means equipment such as a walker, wheelchair, or home oxygen equipment that meets these criteria. It can withstand repeated use. It primarily and customarily serves a medical purpose. It generally is not useful to an individual without an illness or injury and is appropriate for use in the home. It requires health insurers to provide clear information to patients regarding their out-of-pocket exposure for the purchase of items of durable medical equipment. It would direct a provider of durable medical equipment to inform a patient whether it would be more cost-effective for that patient to purchase a specific item of durable medical, and I found another typo this morning, equipment, not insurance, whether it would be more cost-effective for the patient to to purchase the specific item for cash rather than using insurance. And it prohibits a health insurer from, or it says a health insurer cannot prohibit or penalize a provider of durable medical equipment for disclosing to an insured the cash price for an item or for providing information to an insured about the insured's cost sharing amount for the item of durable medical equipment. So for some of you, this may sound somewhat familiar. It's similar to the prohibitions on gag clauses, as they've been called, for in pharmacies for prescription drug prices that you passed a few years ago. So it's sort of a similar type of information to the consumer and prohibition on limiting what the seller can, or the provider can, inform the patient about. Then we get into, as Senator Lyons mentioned before we started, the health insurance coverage for hearing aids. This is a bill that is either on your wall or in the Finance Committee. Or no, I guess it's in the House. This time it's in the House. It was in Finance last year.
I don't think, Senator Cummings, you're muted.
You don't think you have it this year?
Yeah, no, I don't think
Yeah.
we have it this year.
No,
It didn't make it out last year.
Right.
And
That's exactly right.
and we had a similar bill in health and welfare at one point, and then it got moved over to you in finance. But again, and this is
It was cost.
Yeah, so DFR is working with other interested parties on this issue, so we'll hear from them.
Right.
about
They're not necessarily working specifically
No,
for
on the
on the
benchmark.
hearing aid part
Yeah.
piece, but yes, so I think some of it will make more sense as we go through.
Okay.
This would add a new section to the statutes on hearing aids. And what's important for this is the definition of health insurance plan, because it's really defined in a way that does not include the individual and small group plans sold both in and outside the exchange, or the reflective plans. So this means it defines it as a group health insurance policy or health benefit plan offered by a health insurer, and includes Medicaid. So it does include a Medicaid and any other plan offered or administered by the state or a subdivision or instrumentality of the state. So that pulls in the state employees plan and the plans offered to teachers. But it does not include a qualified health benefit plan or reflective health benefit plan offered in accordance with those statutes, or a policy or plan providing coverage for a specified disease or other limited benefit coverage. So I'll take a pause here to explain why it's written this way. And this is some of what you'll start to get into with DFR as well. There is a requirement under the Affordable Care Act, and we may have talked about this before, that the state pay the cost of any new health insurance mandate enacted after 2011. So for the qualified health plans, for the individuals, for Vermont individual and small group market plans, if you were to enact a requirement that those plans cover hearing aids, the state would have to pay all of the additional premium attributable to that new mandate. That's what's called state defrayal. So this is written to take kind of an incremental approach so that the mandate would apply to the large group and to the governmental self-funded plans, which we can regulate. It would apply to them now, or starting in 2022, and then set up a process for trying for looking at changing the state's benchmark plan to include hearing aid coverage. But you'll hear from DFR more about the benchmark plan and what's involved in that. It's not as simple as just adding a benefit. You have to make other changes as well. So that's why health insurance plan is defined to really be large group, including state employees and teachers, and also Medicaid for this purpose. So then it defines hearing aid as any small wearable electronic instrument or device designed and intended for the ear for the purpose of aiding or compensating for impaired human hearing, and any parts, attachments, or accessories, including ear molds and associated remote microphones that pair with hearing aids to improve word comprehension in difficult listening situations in live or telecommunications settings. The term does not include batteries, cords, large audience-assisted listening devices, such as those designed for auditoriums, or standalone assisted listening devices that can function without a hearing aid. Hearing aid professional services is the practice of fitting, selecting, dispensing, selling, or servicing hearing aids or a combination, including evaluation for hearing aid, fitting, programming, hearing aid repairs, follow-up adjustments, servicing and maintenance of a hearing aid, ear mold impressions, and auditory rehabilitation and training. Hearing aid professional is an audiologist or hearing aid dispenser licensed under the professional licensing statutes. Physician, so an osteopathic physician or a medical doctor, a physician assistant, or an advanced practice registered nurse. So then it requires a health insurance plan to cover the cost of a hearing aid for each ear and the associated hearing aid professional services when the hearing aid or aids are prescribed, fitted, and dispensed by a hearing care professional. The coverage provided by a health plan for hearing aids and associated services shall be limited only by medical necessity. But a covered individual can select a hearing aid that's in excess of what's medically necessary and pay the additional cost. The coverage required by the section shall not be subject to a deductible, co-payment, or co-insurance requirement that is less favorable to the covered individual than those that would apply generally to other non-primary care items and services under the plan. And then it specifies that a covered individual who has exhausted all applicable internal review procedures provided by the health insurance plan shall have the right to an independent external review as set forth in statute, except for Medicaid. A Medicaid beneficiary's grievance would be redressed by the Human Services Board as set forth in 3 VSA section 3091. So that's health insurance coverage in that large group and Medicaid. And then section 13 would direct, and the timeline looked a lot more manageable in January, but on or before May 7th, 2021, the Agency of Human Services, in consultation with DFR, where you're going to hear from, and the Green Mountain Care Board, must apply to CMS to modify the essential health benefits in Vermont's benchmark plan to include coverage of hearing aids and related services at a minimum standard of medical necessity beginning in plan year 2023. And so that the reason for this date is that that is the deadline under the federal requirements to apply to change your benchmark plan for plan year 2023. So if you did something after that, it would be for a later plan year. It directs the agency to contract for actuarial services to the extent necessary to prepare the actuarial certification and report required as part of the application process. It would have had the agency provide a draft by April 1st of 2021. So obviously we'd have to relook at the dates. The agency provide a draft of its completed application materials, including the actuarial certification and report, to the Medicaid and Exchange Advisory Committee and the Office of the Healthcare Advocate, and make them available on its website. It would require the agency to accept public comment on the application materials, to respond to all public comments, and to incorporate the public comments into the final application materials when practicable. And it would require the agency to provide periodic updates on the disposition of its application to the House Healthcare Committee, this committee, the Finance Committee, the Medicaid and Exchange Advisory Committee, and the Office of the Healthcare Advocate. Section 14 would direct the Agency of Human Services to seek approval from CMS to provide coverage of hearing aids for individuals enrolled in Medicaid, as set forth in that earlier section that actually spelled out the coverage. Because that is in excess of the existing coverage requirements in Medicaid. So we're getting close to the end. Section 15 is a change to the State Health Improvement Plan, which is an existing requirement for the Secretary of Human Services or designee. This would specify that it would be, in fact, the Commissioner of Health, not the Secretary or designee, in consultation with others who would adopt the State Health Improvement Plan and amend it as appropriate. Then we get into some reports. Section 16 would have the Green Mountain Care Board by January 15th, 2022, provide to the House Healthcare, this committee, and Finance an analysis of the increases in health insurers' administrative expenses over the most recent 5-year period for which information is available, and a comparison of those increases with increases in the Consumer Price Index. So look at increases in health insurers' administrative expenses with increases in the Consumer Price Index. Section 17 directs the Director of Healthcare Reform and the Agency of Human Services to provide information by January 15th of 2022 to this committee and the House Healthcare Committee regarding the manner in which specialty care will be incorporated appropriately into the all-payer model and when that incorporation would occur. Section 18 directs each accountable care organization certified by our existing processes to provide information by January 15, 2022 to this committee and House Healthcare, provide a description of the ACO's initiatives to connect primary care practices with social service providers, including the specific individuals or position titles responsible for carrying out these care coordination efforts. So report on exactly what it is that they're doing to connect primary care practices with social service providers, including whose job it is to do that. Section 19 has some reports on what it would look like to have at least two primary care visits per year without cost sharing. So the first part requires DVHA in consultation with DFR, health insurers, and other interested stakeholders to provide an analysis by January 15, 2022 to House Healthcare, this committee, and Finance. This analysis would be of the likely impacts on qualified health plans, patients, providers, health insurance premiums, and population health of requiring individual and small group health insurance plans to provide each insured with at least two primary care visits per year with no cost sharing requirements. And then a separate report from the Green Mountain Care Board in consultation with DFR and the Department of and DHR of Human Resources to report, health insurers and other interested stakeholders to report by January 15th, 2022 with analysis of the likely impacts on patients, providers, health insurance premiums, and population health, so the same criteria, of requiring large group health insurance plans, including plans offered to state employees and to school employees, to provide each insured with at least two primary care visits per year with no cost sharing requirements. And then finally, we get into the effective dates, which we can go through, or we can hold those for another time, whatever you prefer.
We can hold those unless someone
Okay,
read them. We're good. Okay.
just know they're there.
Questions for Jen? Okay, so there are a number of things I think in the bill that require analysis and study. So, and some of those, including the last sections on primary care, are things that we might want to fold into a single. There are a number of things in the bill, including the primary care, that we may want to fold into a single analysis or set of analyses. So, and then one comment on the health improvement plan that was traditionally done in the Department of Health. That plan, I think we should ask to have updated by a date certain, if we can do that. And I don't know what the requirements are in statute in terms of an annual update, or do you remember, Jen?
I think the language was to update as the commissioner or as the secretary or designee deems appropriate.
Yeah, okay.
Let me just pull up some of that is in the bill.
Yeah, I know. I just think it might be helpful to have it updated, because it can be, the data that's collected by the health department is important in informing the Green Mountain Care Board around the health resource allocation plan, which is then used for CON and other distribution of services. So that's the reason that that's in there, and we haven't talked about it in a long time. We can get someone in to talk about that if people are interested. I'm interested. But, okay. All right. So you're all set to vote it out, it sounds like. Sorry. Go ahead, Ruth.
There's just a lot in there, and it's and a lot of it's sort of, I mean, it's obviously all related, but there's
It's
a
a
lot
lot.
that's not directly related. And the sort of regulatory changes, it's hard for me to sort of figure out what impact they would have. Yeah.
So I completely agree with you. I think that it was meant to stimulate some conversation. And I think as we hear testimony, and as you heard yesterday from Ina Backus, some of the recommendations that they're going to be making about the all-payer model next gen to ask for some changes. Some of what's in this bill, A, may not need to be done, but B, also might, as I said before, fit into some kind of analysis, either with an independent consultant or within the Green Mountain Care Board or AHS. So there are some choices there, or whether we even want to pursue some of those at this time based on what we're hearing from folks. So there's no, I'm not committed to moving this.
Okay.
Senator Cummings.
No, I'm just struggling with timing. We worked on hearing aids. And again, I see that you're pretty much limiting it to state employees, but at the present time, we're struggling over whether or not we can afford state employee pensions, and to be increasing health care coverage at the same time is a lot.
So I think you're right. There's a lot here, but the goal is actually to improve access, also affordability. So, and we know how critical hearing aids are to sort of mitigating the effects of aging, Alzheimer's and senescence.
So are dentures. So just assume that dentures are coming next.
Yeah, they may as well.
Yeah, but who pays for retired employees' health care? I know we pay for teachers. Who pays, if you're retiring at 60, who pays your health insurance?
Well, you go to Medicare, remember that.
Not until 65.
Yes.
I do think that there is I think that some of the other post-employment benefits is not my area, but I think
are we adding, my question is, are we adding to the pension cost? We definitely would be adding to the cost of teachers' retirement.
I don't know that the language as written applies to retired employees.
But we provide health care for retired teachers.
Yes, but that's not the language it talks about school employees, not retirees. But I think would need to hear from.
The bulk of people I hear from hearing aids are retired. And that's
so, but
where the need.
Also, then, if it's an early onset hearing loss, that could be.
That's one thing.
Significantly more important in terms of living one's life with quality outcomes.
Does Medicare cover hearing aids, Jen?
No,
not at all. Senator Hooker.
I like everyone else has said, there's a lot here, and I was just wondering about Medicare and how that fits in, because I know it doesn't cover hearing aids. what other implications does this have for Medicare?
Nothing. You can't affect
Nothing.
Medicare. I mean, you
Yeah.
could create a state-only benefit that you provide to people who are
On Medicare.
on Medicare.
Yeah.
You know, you've done
Like
that with in prescription drugs with V-Farm. You've done a wrap.
Yeah.
But that
So-
would be all state dollars.
Yeah, and that is a significant portion of the population, I would
And
think.
it's growing every day. You know what I'm going to suggest, because we're in this conversation and it's moved to hearing aids. I suggest that we hear from Jill Rickard and Emily Brown, who are here from DFR. And Jill, thank you for being here. Why don't we hear what you have to say about what you're doing at this point? And that would be very helpful. Maybe inform us about what we can do within the legislative process to facilitate some outcomes.
Sure. Thank you, Madam Chair. My name is Jill Rickard. I'm the Director of Policy for DFR. We have applied for a 2-year grant from the Centers for Medicaid and Medicare Services to perform analysis related to our market. And part of that analysis is actually the largest part of the grant is going to be focused on reviewing and analyzing our benchmark plan and whether to change the benefits around or to add new benefits such as hearing aid coverage. That is something we're interested in looking at. Of course, it takes actuarial analysis, because when you increase the benefits in one place, you have to decrease the benefits in another place. And so we're engaging an actuary, which is a pretty expensive process to do that, which is why the timing in this bill is not workable if we wanted us to look at that during that process, because there are state defrayal costs if you add new benefit mandates. So what we would propose is to give us time to take advantage of this really generous grant that we're expecting to receive any day now from CMS, to explore the benchmark plan. Is if you would push out the dates all by 1 year, such that we have, because it is a long process, to do the actuarial analysis. Then we'll have to propose the new benefit mandates. Those have to be approved by the Green Mountain Care Board. And then AHS would need to propose those to CMS, that then would have to approve them. So that would take a year or more. We could get it done in a year, and if you moved those dates out all by 1 year. But then once they're approved by CMS, they would need to be effective for the 2024 plan year.
Well,
Our
whatever
suggestion is
dates
to-
work for you. I think, I'm sorry, did someone else want to say something? Did I interrupt?
Go ahead.
I think you did send along a note about this. And I don't know if you included Jen in that communication, but if you could do that, and we could maybe modify the language somewhat so it conforms with the work that you're doing, and so that we understand the work that you're doing and the report that's coming back, and whether or not you're successful with a grant, that would be very helpful.
Two other comments, Madam Chair, if you don't mind. That
Absolutely.
This doesn't speak directly to the state employee plans or Medicaid. Of course, this is only going to our benchmark for the exchange plans. But it may make sense if the committee decides to also push that out to 2024, so that it is informed by the analysis that we're performing on our benchmark. And the other thing is, I do believe that Vermont Medicaid does currently cover hearing aids. So you may want to hear from DEVA on that aspect, because that may not be necessary.
I think, just to clarify, I think they do cover it, but it not to the extent, necessarily to the extent contemplated by the bill.
Go ahead, Ruth. Senator Hardy.
No worries. Jill, thank you, Madam Chair. Jill, this grant that you're getting sounds great. And wondering if there are some specific topics that you are planning on asking and looking into about in this analysis. It sounds like hearing aids is on your list. Are there other areas that are on your list?
Do you mean other new benefit mandates that we could look at?
Yeah, other things. I mean, I'll just throw another one out there that I'm interested in learning more about. There's no bill on it, but I am working on something for next session about fertility coverage. And I know that's super expensive. So I would love to get more information on that. And I'm sure we all could come up with other things. So I'm wondering if you have a list, and given the timing, it seems to me that we might want to hold back on implementing new mandates, even without effective dates out into the future, and wait to hear what your analysis says, and then sort of decide what is reasonable and possible. That's my thinking, but I would like to know what's on your list to look at.
So thank you for that question. That is what we would propose as well. I think that's a great idea. We would invite the legislature to, if there are things that you're interested in us looking at, we'd be happy to look at them and add them to. I don't think we have a specific list at this point. But again, I think my colleague Emily is leading the grant process, so she can maybe speak to that a little better.
Okay.
Thank you. So to your question, Senator Hardy, part of this whole benchmark updating process, while I think, a lot of the cost and the analysis will go towards the CMS application and the actuarial analysis there, before that even happens, the state has outlined kind of the state's internal process of how we're going to go about updating the benchmark plan. And that, I believe it's on DVHA's website, and if you're interested, I can put that along. But that process, we're envisioning it as being a stakeholder engagement. So, having the issuers involved in that, the healthcare advocate, any other interested parties, where I think that will be an opportunity to kind of talk about policy objectives as well, and what benefits are people, or what needs are people seeing in the market that aren't being addressed. And then have that be more of a collaborative effort to say, okay, these are the areas we think we should focus on, and then have it be definitely a collaborative and kind of participatory process, instead of it just being like, okay, we're just going to focus on these benefits. We want to be able to make sure we're understanding and studying the market, rather than assuming that we know where the needs are and what needs to be added. So other states, for example, other states have done this. I know Illinois is one state that has updated their benchmark plan, and they wanted to focus on mental health and substance use disorder to try to tackle the opioid issues. So they were focused on that and up their benchmark plan accordingly. So I think it just depends on, what comes out of our stakeholder engagement, what we find maybe that other states are doing that we could see could benefit Vermont. So I don't think, I'm trying not to go into this process assuming that I know, what things should be added or shouldn't be added. I think it really just needs to be like a collaborative process, and, with many stakeholders to try to work through this. But I also would say it would be very welcome if the legislature had issues or policy objectives that we should consider. I think that would be great, and maybe provide that more of a direction for this process, and some pointed areas that you all would like us to look at.
That
Yeah,
would be
good.
great. Thank you, Emily. That would be great. I think that rather than trying to push forward something, even with extended dates, just providing a list or guidance about what we're interested in hearing about. And certainly, hearing aids is one of them for sure. And I'm sure others, we could come up with a nice list, and that wouldn't mandate anything, but would help you with your thinking, and would be easier for us to tackle at this point in the session, I think, as well.
So thank you, Senator Hardy. That's well said. And I think by hearing aids for me are at the top of many lists. But so, and why don't we do this? Send your comments, please, you, Jill and Emily. You've heard the conversation. you can help us modify this language wherever it goes. We don't know where it's going to go. But so if you can do that, and then in the meantime, we'll also be thinking about those changes that might help from our perspective on the benchmark plan. You've already heard two. I don't know how dentures fits in this, but we've heard that one, and I know we hear it over and again, particularly with the increased age of our population. And then, and you brought up mental health and substance use disorder treatment, and that's been an ongoing concern from both with private insurers and our Medicaid folks about the extent to which folks can be treated. How many counseling sessions, for example, has always been difficult to determine. And so I would welcome that one on the list as well, or those two. Senator Hooker.
And I've also heard from home health agencies that they would like to see more follow-up for people who are dismissed from hospitals, so that, you know, they don't have to return to the hospital because they haven't had enough care and follow-up. And I don't know how that would fit in, but certainly something that I think needs attention.
Yeah, I know that fits in a lot of different places, including the coordinated community service issue that we've been looking at. So, okay, this is very helpful. Jill, thank you for reaching out in the first place. Really appreciate it. And I think something good might come of this. I think the good you're doing is certainly going to come of it. And as you know, legislators are not apt to be available all the time to give input in a stakeholder process, but we certainly can add our thoughts at this point and help things along. Senator Hardy.
Thanks, Madam Chair. I was just thinking of strategy about vehicles for this type of thing, and also potentially for the next bill that we're going to go over. And one bill that we have from the House that might work, I don't know, Jen, I would obviously defer to you, is the H430, I think it is, the Dr. Dinosaur bill, because that's about expanding coverage under Medicaid, and we might be able to make that argument that this is about looking at other areas that we could potentially expand coverage. And S120 is also that. So there might be some provisions in this bill and the next bill that could fit in that, if we can make
that's going to be our ongoing discussion and challenge. It's good.
That was just a thought I had last night, and looking at the bill, it seems like
listen,
something might be possible. If you want to look at that, Jen, and see what you think.
I think you probably want to talk to Secretary Bloomer, because it's going to be up to him whether something is germane or not.
So we'll have a broader conversation about that after we've completed some of the work on the bills. Okay, Jill and Emily, is there anything else that we need to hear and we need to know at this point?
I don't believe so. Excuse me, I was going to sneeze there. The other sections on durable medical equipment and the studies about 2 primary care visits, we are fine with those as well, just to put it on record.
Okay, that's good to hear. All right. Yeah, no, how those studies end up and where they end up, I think will be important. The primary care visits have always been kind of the barrier. If you have to lay out a copay, you may not go when you should for prevention, and that's one of our goals. But thank you for that testimony.
Thank you for the opportunity.
All right. Okay. So committee, any other discussion on 132? I think there are some sections that I'm willing to forego. We'll certainly hear from other people as we go forward on the bills next week. But I think as we identify things that resonate with others and can happen without a lot of debate, we'll keep moving those forward. Okay. So Jennifer Carby is here on S120. Thank you.
Sure, I will put that one up now, just moving it over.
Senator Hooker, you're the lead sponsor. Do you want to add anything?
Just
she
that
go?
this, I'm here.
Okay.
Just that I think that this is important that we start, that we look at ways to certainly increase access and affordability. This is one way to do it. We're hoping that this bill will help us to position ourselves as a state when things start happening at the federal level. And, it's a step forward, I think. So, and maybe Senator Hardy would like to weigh in on it as the other lead sponsor.
Sure. I think that there is a potential opportunity for, as Senator Hooker said, to expand access and affordability with a new administration in DC. And we just wanted to make sure that we had the ability to lay the groundwork for that on the off session, and also to build capacity among legislators for understanding and leading on this issue next session, if there is an opportunity for such a thing. Specifically expanding down the age eligibility for Medicaid and or Medicare, and maybe expanding up the age eligibility for Dr. Dinosaur, and finding creative ways to work with the federal government on this, and also looking at our own system. So it's similar to what we were frankly just talking about, but ways to expand coverage with also maintaining affordability, which is a really tough thing to do. So this is just off session work to try to get at that and in a focused way. So.
Okay, so, and I'm going to suggest that as we go through the bill, and then when we go back through 132, there may be some things that we want to combine, because we've been, we'll talk about all this stuff, and we throw it all in the hopper, and out will come something. I'll end it there. Out will come something.
The
Okay.
sausage will get made.
You got it. Okay, Jen Carby, thank you.
All right, there we go. This is S-120, and as you know, it was introduced by 3 members of this committee, Senators Hooker, Hardy, and Cummings. It is an act relating to the Joint Legislative Healthcare Affordability Study Committee. It starts out with findings. So it has General Assembly finds that the COVID-19 pandemic has caused significant job losses, with women especially impacted, likely causing a significant negative impact on the number of Vermonters without health insurance and placing greater financial strains on those who are underinsured. Second, many Vermonters who have health insurance are still exposed to high out-of-pocket costs through their plan's co-payment, co-insurance, and deductible requirements, in addition to ever-increasing premium rates. Currently, a family of 4 earning more than $105,000 per year who are enrolled in a silver plan through the Vermont Health Benefit Exchange may pay as much as $44,000 per year for health care between their health insurance premiums and out-of-pocket costs. In some instances, an individual or family may have health insurance but not be able to afford to receive necessary healthcare services because of the out-of-pocket costs associated with their plan. Others who lack coverage or who are underinsured and receive necessary healthcare services find themselves saddled with substantial medical debt. Third, employers across the state, including local municipalities and school districts, small businesses, and community organizations, face significant and persistent budget pressures due to the increasing cost of healthcare coverage for their employees. Fourth, hundreds of Vermonters lack access to any health insurance coverage due to their citizenship or immigration status, and many younger adults cannot afford to purchase adequate health insurance coverage. Fifth, Vermont is facing a significant shortage of healthcare providers, especially primary care physicians and nursing professionals in many areas of the state. And finally, the Biden administration has indicated interest in using its demonstration and waiver authorities to partner with states to pursue certain reforms that cannot be accomplished through Congress. The administration has signaled that it may be open to working with interested states to test strategies such as an expanded public option for health coverage. So those are the findings. And then it creates this committee in section 2. So there is created the Joint Legislative Healthcare Affordability Study Committee to explore opportunities to make healthcare more affordable for Vermont residents and employers. The committee would be composed of the following 6 members: 3 current members of the House of Representatives, not all from the same party, who shall be appointed by the Speaker of the House, and 3 current members of the Senate, not all from the same party, who would be appointed by the Committee on Committees. The committee is directed to explore opportunities to make healthcare more affordable for Vermont residents and employers, including identifying potential opportunities to leverage federal flexibility and financing and to expand existing healthcare programs. The committee shall consider the following: the long-term trends in out-of-pocket costs in Vermont in individual and small group health insurance plans and in large group health insurance plans, the efficacy of Vermont's all-payer accountable care organization model, and the changes to the model that would be necessary to make healthcare more affordable for Vermonters, or whether an alternative model may be more effective. The extent to which Vermont's uninsured rate may have increased during the COVID-19 pandemic and the specific causes of any such increase. Opportunities to decrease healthcare disparities, especially those highlighted by the COVID-19 pandemic and those attributable to a lack of access to affordable healthcare services. And opportunities made available by the Biden administration to expand access to affordable healthcare through existing public healthcare programs or through the creation of new or expanded public option programs, including the potential for expanding Medicare to cover individuals between 50 and 64 years of age, and for expanding Vermont's Dr. Dinosaur program to cover individuals up to 26 years of age to align with the young adult coverage under the Affordable Care Act. In order to gain a fuller understanding of the impact of healthcare affordability issues on Vermont residents, the committee would be required to solicit input from a wide range of stakeholders, including healthcare providers, healthcare administrators, Vermonters who lack health insurance or who have inadequate health coverage, employers, labor unions, members of the New American and Black, Indigenous, and people of color communities, Vermonters with low income, and older Vermonters. Beginning on or before September 15th, 2021, hold not less than 8 public hearings, each in a different Vermont county, to gather information from stakeholders and other members of the public. Public hearings may be held in person or by remote means, and each public hearing would begin with a panel discussion involving committee members and local stakeholders selected by the committee, and include an opportunity for public testimony. And a summary of the findings from the field hearings would be included as an appendix to the committee's report. The committee, through the Joint Fiscal Office, would hire a consultant to coordinate the committee's work. In addition, the committee would have the administrative, technical, and legal assistance of the Office of Legislative Operations, the Office of Legislative Counsel, and the Joint Fiscal Office. On or before January 15th, 2022, the committee would present to the General Assembly its findings and recommendations regarding the most cost-effective ways to expand access to affordable healthcare for Vermonters without health insurance and those facing high healthcare costs, and the various options available to implement these recommendations. The first meeting of the committee must occur by July 1st of this year. The committee would select House and Senate co-chairs from among its members at its first meeting, and the co-chairs would alternate acting as chair at committee meetings. A majority of the committee's membership would constitute a quorum, and the committee would cease to exist on January 15th, 2022, which is when its report is due. Then there's the compensation and reimbursement. So for attendance at meetings during adjournment of the General Assembly, the members of the committee, because they're all legislators, would be entitled to per diem compensation and reimbursement of expenses under 2 VSA Section 23 for not more than 12 meetings. These payments would come from monies appropriated to the General Assembly, and the bill would appropriate $175,000 to the Joint Fiscal Office from the General Fund in FY22 for a consultant to coordinate the activities of the committee and to cover related costs of actuarial analyses, research meetings, and the per diem compensation and reimbursement of expenses for members of the committee. And the act would take effect on passage.
Okay. Why don't we take it down? Questions? So it sounds like the actuarial analysis will be done on the expansion of things like Dr. Dinosaur. And then, but the bulk of the work is to go out and listen to the public and gather data from the public. Is that accurate?
Yeah, go ahead, Cheryl. Did you?
Say yes, I think so.
Yeah.
Certainly, Dr. Dinosaur and Medicare expansion are two of the possibilities. I think, if we find that there are other ways to affect this access and affordability, then, those two will be considered. But that's what, the intent is so far. Would you agree,
Okay,
Senator?
okay. And as I'm looking at it, your interest is in having the legislators go out in the field, listening and setting up meetings across the state.
Mhm.
And then while at the same time, there will be a consultant analyzing information that is directed in the bill. So I'm trying to put those two things together. Was there any thought about taking the data or information that you get from the what might be gotten from the testimony and trying to analyze that? So it seems like there are two separate things here. One is a group going out and listening and gathering information and collating that information. But the other is a consultant analyzing two very specific things. One, Medicare, the other, Dr. Dinosaur.
Yeah, I think you're right that there should be a connection between the two of those, and that there's.
I don't know. Maybe not. It could be
I
value
think,
in both.
Right. There's wanting to hear from the public, particularly in this post-pandemic, hopefully post-pandemic, end of pandemic, about access and affordability of healthcare coverage, and what people are experiencing on the ground. And also sort of thinking about that in the context of the goal of our state, which is universal coverage and universal healthcare for everyone. And, is that happening? And if not, how can we make it happen? And those two ideas are in the bill, but there may be other ideas that we hear, and also ideas that come to us from the feds. And this is really in connection with the other work that's going on in terms of our global commitment and all the payment talk discussion we've been having too, because I think that is obviously those are part of the puzzle.
Okay, so and just before we go to Josh, Senator Terenzini, then one of the findings is about the uninsured in our state, and we do have data on that, so it'd probably be important to understand what that means. All right, Senator Terenzini.
Thank you, Senator Lyons. My question probably piggybacks what you just said. I was wondering, do we know from the pandemic how many people are uninsured as a direct effect of the pandemic?
Nolan's saying no.
I see Nolan saying no.
We don't know that directly.
Let Nolan answer.
Oh,
go ahead, Nolan.
I think Senator Hardy can answer too. I think we don't know.
That's right.
We do a survey every 2 or 3 years, and that's the data that we have. My understanding is that the health department will be doing the survey again. It's called the Vermont Household Health Insurance Survey. It's my understanding they'll be doing it again this fall. So we'll
Right, it's required every 3 years by statute.
Yeah.
And Senator Lyons, I think anecdotally we've heard that people have, who have lost their jobs have lost their health insurance. And so anecdotally at least, it seems as if uninsured or underinsured are, the numbers have been rising.
Senator Cummings.
Nolan, have we seen an uptick in Medicaid? Because that's usually the process. If you lose your job and lose your health insurance, your next step is Medicaid.
Yeah, so
And I-
the problem with that is because of the CARES Act FMAP increase,
Okay, they
have
don't,
MOU or we have a moratorium on redeterminations. And so in short, there's no churn. People can come on, but they don't come off right now. So it's hard to determine if there's new people that wouldn't have stayed on, like, if the overall. So the numbers are clouded and it's hard to know. I think the answer is probably yes, but we can't tell from the data because it's too much noise in it.
Okay. Other questions? So one of my questions was going to be why not have the Health Reform Oversight Committee, and by the way, I'm very interested in changing the name of that committee, but why not have that group be involved in this process with the group of folks who have a foot in the door of finance and appropriations as well as healthcare. But it sounds like you're more interested in having folks going across the state and gathering information from interested parties rather than having the group make specific decisions and recommendations, except for as completed by the consultant. I'm trying to sort out the thinking behind that.
Yeah. Senator, sorry, Cheryl, I don't want to keep stepping on you if you're gonna. I would say that that's a great idea to have that health reform oversight or whatever it's called, or whatever new name you would like it to have, involved or consultant. That actually hadn't occurred to me. So I think that that's a good idea. I think that, one of the things that in talking about this bill that Cheryl and I, or Senator Hooker and I, have talked about is when we all go out and campaign, what we hear from our constituents as the number one problem, the number one concern they have is healthcare. And, I heard that time and time again, both times that I was out campaigning, especially the first time when I was knocking on thousands of doors. And it doesn't feel like what we talk about here is necessarily connected to what we're hearing out in the field all the time. And so a lot of this is what are people in our community saying about the type of access they have? How expensive is it? And what is the sort of like real Vermonters on the ground? What are they experiencing? And how can we learn from that as legislators when we're not campaigning, that it's, part of our job, not a part of our politics, if you know what I mean. And then taking that and using it to create policy with the help of a consultant who has some expertise, while also building the capacity to do this work next session, sort of hit the ground running. And it's super connected to some of the things in your bill and other bills that we're talking about. And I think, combining efforts is a great idea.
Okay, I get it. Thank you. Anything else? All right. Okay. All right. So we will pick up some testimony on the bill, and we'll try to sort out the best way to go forward, what to add, what to subtract, what to perhaps modify, and then what to do with it, which is the last question. Maybe it should be the first. We got to figure out how to move it along, and we will do that. And part of it may end up being incorporated into the budget. We don't know. That frequently happens to some of our bills at the end of the session. All right. Before we move on and back to, and we will come back to this, before we move back to the Green Mountain Care Board, I've invited, yesterday, Robin Lunge, or I think it was Robin, who mentioned the primary care pilot program. Was that you, Robin? Yeah, I thought so.
Yes.
That's going on at ACO, and I thought that we should have those folks in. We have a few minutes to hear about that. So Vicki Lohner and Tom Bories are here from the ACO. Welcome, both of you. Good to see you.
Thank you very much. Great to see you too. I brought with me today Tom Bories, who's our Vice President of Finance, which I think he's been in
Yes.
to meet with you all in the past. And we thought we'd just give you a really brief overview of our comprehensive payment reform pilot, which has been in effect since 2018, when we started under the all-payer model. And this is a program that was designed specifically to meet the needs of our independent primary care providers. And, we started off with a very small group of independent primary care that wanted to take this journey with us because they knew with any kind of new reform effort that the journey was going to be a little bumpy at first. And over the years, we've seen that the program has really been growing in size. And we'd like to take this year, actually, we had a discussion about how do we simplify and standardize the program more so that we could offer it not only to independent primary care physicians as well as FQHCs and hospital physicians, because we've really seen during this pandemic that the predictability of the payments has been a real bonus for the primary care physicians. Last year alone, when we did the calculations, the primary care physicians were better off financially by about $1.5 million. So this is substantial for, I think it was around 7 or 8 practices last year. And with, growing uncertainty, I think that predictability of payments is really key. So I want to just turn it over to Tom, who's a real expert on, this program design, and he's really been instrumental in working with the primary care physicians to move the program along. Over to you, Tom.
Great, thanks. Hi, everyone. Nice to see you again. So I'll start with a really high level overview of the program and what its intent is, and then I'm happy to entertain questions. It is a complicated concept, so wherever you want to go with this will be great. But when we envisioned this program back in 2018, we're really trying to find a way to pay for primary care differently. And in our historical fee-for-service world, a primary care office was paid for every visit they did, and there's an incentive to do volume, which really isn't the problem in terms of total costs. We encourage primary care. That's a good thing in our view, but really it puts pressure on primary care to be extremely efficient in their office schedules. They have to get people in and out the door all day to meet revenue targets. So we thought that wouldn't it be great to change that to a different payment model where we pay primary care based on their panel of lives, their patients. So what we do in this program for participants who would like to participate is we work with the payers, Medicaid, Medicare, and Blue Cross in this case, to turn off the fee-for-service reimbursement to the practice and instead pay them a monthly per member per month payment that is adjusted, risk adjusted for their specific panel of lives, and replaces that fee-for-service reimbursement with that stable monthly fixed payment. The idea is that having this stable monthly fixed payment coming into the practice enables the providers to more flexibly or fluidly care for their patients. They could spend more time with somebody who needs more attention. They could spend time doing phone outreach or email outreach if that's appropriate in their clinical judgment, and take some of the pressures off that come from needing to really monitor fee-for-service volumes in order to keep their business afloat. In addition to paying differently, we also supplement the payment. This is our most progressive payment reform model for primary care to help them with this transition. And those supplemental payments yield the outcome that Vicki spoke of, which is significant financial benefit in 2020. Now, some of that was COVID related, where volumes were down for a period of time. We've seen some interesting trends in that way. And having that monthly fixed payment come in yielded some additional financial benefit. But even absent the COVID circumstance that we all have been living through, the program is designed to supplement the investment to primary care. Overall, over time, I think we've had really good success in the program. The growth is evidence of that to me. It's not easy though. This is a big change to entrust OneCare or anybody to turn off the fee-for-service and make a monthly fixed payment to a practice is a big deal and a big responsibility for us at OneCare. And it is a huge paradigm shift. We have all in the healthcare community become very accustomed to being paid for each unit, each claim that is billed. And in some ways that is a good thing, where if my practice changes, I add a service, I expand, fee-for-service will flow with that. In this payment model, it's a different concept, and we just need to work with practices as they evolve and change over time to build in the right kind of flexibilities while sustaining this concept of paying for primary care on a panel basis rather than a unit basis. Let me pause there for questions.
So let me ask a question first, and then Senator Hardy has a question. As you're doing this, obviously Medicaid and through the Medicare waiver that you can act, those patients are covered through the per member per month payment. But then also you've indicated that Blue Cross Blue Shield as a payer is involved with this. So, but how many patients from the private payers are being covered in this way? I mean, so obviously it increases access because the providers can provide it more effectively and with some reassurance sustainability. But how difficult has it been, or how have you gotten the private payers to be engaged in this process?
Yeah, really good question. So Blue Cross, this is the first year in 2021 where Blue Cross is offering us this fixed payment option. So it's a nice evolution for the program so that we can get more of a practice's business into this model and start to erode that foot and two canoes problem where you have some fee-for-service and some of this new progressive payment model. As we look forward at OneCare, working with the other commercial insurers to develop a similar fixed payment model would be a nice evolution into the future years, and something we look forward to bringing to the practices.
I would say, Senator Lyons, that, you know, for the insurance companies that are Vermont domiciled, this is a little bit easier of a lift. There is that challenge, though, for those insurance companies that are offering coverage to Vermonters, but aren't, whose primary location is not within Vermont. So I think that's something that we're going to have to consider as we move forward. How do you get some of those carriers involved in this particular model? And I think the other component that we still have to tackle is self-insured. And how do you bring capitated type payment into self-insured when they're already at risk? So that's one of the things that we'd like to be able to figure out next before we even think about the out-of-state insurance companies. But the self-insured is a very big group of participants in Vermont that it would be good to understand how we could bring them into this type of model.
Thank you. Senator Hardy.
Thank you, Madam Chair. So we heard a couple days ago from primary care practices that we heard sort of mixed messages. On one hand, they were happy to have these capitated payments during the pandemic because they knew that they would be getting revenue. But on the other hand, we heard from them that they were fairly inflexible, that they didn't take into consideration the addition of new patients throughout the plan year, or new services or new providers. And I'm wondering how you're going to, or if you're going to address any of those concerns moving forward.
Sure. Yeah, it's a good question. So, I mean, that's one of the learning experiences that we have with this type of progressive reform is that paradigm shift away from I do more, payment flows with it. And there's some cases in which that makes perfect sense. If a provider or an office adds a doctor, there should be some payment increase. This gets a little bit complicated though when it comes down to attribution. We are making a panel-based payment based on the lives that come to us at the beginning of the year, and that's basically a static list that won't grow or change. So if a practice adds a new provider and they see all unattributed patients, for example, helping with our access problem in the state, those claims will still pay fee for service. If they see a attributed patient, those claims are covered by this monthly fixed payment. And that would be a case where we'd work with the practice to make sure that they're financially supported in this practice change. It's a tricky space. This is finding that balance between fee for service, pay for every unit, and this population-based panel model. So when we're working with practices and also talking internally about the future of the program, trying to find that balance where there's enough fluidity and movement in the program to accommodate change without going completely backwards to paying for units and just getting back to really the fee for service model. It's a tricky spot. So we're working always on evolving this program to find that balance.
So
I think, I was just
Sorry.
going to say, I think Senator Hardy, one of the challenges we had that Tom noted is that attribution list. So the attribution is something that's determined by the payer. And so is the methodology, and that's provided to us at the beginning of the year. And then those particular patients are locked into the ACO. So there's very little room for us at the ACO to make changes or movement in those attribution lists as the year goes on. As we grow, I think that's something that we're going to have to look at with the payers is there a way to be able to add in or subtract attribution as people change, but to hold harmless kind of both the ACO and the provider as we move forward. So these are all things that we're learning, and it's always good to kind of start small with people that are along for the journey and know that there's going to be some bumps because we are learning. So it's been nice that it's, 12 practices, because Tom's been the main point of contact with these practices to be able to really walk through each and every one of these issues to hopefully get to a place that it can be standardized and put out to a larger population of primary care providers, because it really is a nice program.
So as you're talking about how to accommodate for, I think of, I think of school students being paid, per pupil payments, and the money follows the child. We know that discussion that goes on, money following the patient. But the question I have is, if you have all of these practices have invested some risk within the process, is it possible to consider what percentage of that risk could be utilized for newly attributed patients? So I'm trying, as you're talking, I'm trying to figure out a solution. So is that something that you have thought about, or is it a possibility?
I think what we tried to do, and maybe this isn't getting at your question, when we built the model originally, we looked at what their fee for service claims would have been, right? We risk adjust those. And we determine a PMPM based on that, but we also add in some additional investment opportunities so that the practice can adjust to this new payment system and be able to add in, like we saw Thomas Chittenden added in clinical psychologist to their practice counselor.
Right.
With those additional investment money. So we try to build in some additional investment to accommodate for that along the way. And I think what we have to do is determine above and beyond that additional investment, what are some of those other factors that might need to be addressed. And one of the things that we've come up against, I will say, is, as you can see, this is a pretty sizable investment in primary care overall. Last year or this year, we're tuned to make about $19 million in primary care investment. Yeah, our opportunity for financial reward over the program is slightly less than that because we had to reduce our risk and reward due to the COVID situation. And we've yet to see a lot of the delivery system reform dollars materialize. And so the hospitals have been the ones to fund these investments to primary care. And I don't think that that's a sustainable solution either. So we have to think about, if we're really committed and moving forward on this, is there a way for the state to be looking at how to provide some additional investments in these reform efforts to support the frontline care providers as they make this really big transition?
I'm going to ask you to talk a little bit about DSR because I'm not sure that the committee is fully experienced with that, and
Right.
where those dollars are and how they might be available. So
So
delivery system reform dollars.
delivery system reform dollars. So when the all payer model improvement plan was rolled out, there were some funds that were to be allocated through the Global Commitment for Health through the Medicaid 1115 waiver that was supposed to be earmarked for that ACO providers to embark on these payment and delivery system reforms. And there were various categories around care coordination, quality improvement, primary care, designated mental health agencies, and I think HIT. There might have been another. This might not be a perfect list, but I'm happy to get it to you. And what was required was that the federal government would pay essentially like 50%, and then the state had to allocate the other 50%. So it requires an allocation on the state's behalf.
It's a matching process.
The matching process. So what we've seen is that the state hasn't been able to provide the match. And so the amount of delivery system reform dollars has been pretty small compared to what was available. So for instance, this year, we're asking for 3.9 to cover the care coordination that funds programs, I think, near and dear to Senator Lyons' heart, Dulce, longitudinal care through home health, and these primary care investments. And this is indeed the last year that those funds were supposed to be available. So I think we have to think about, is there a way to be able to make those funds available next year as we enter the last year of the all payer model plan? And is there a way, when we think about an all payer model 2.0, is there a way to make sure that some of those dollars are still available going into the next model? Because this type of change in both the way that services are paid for and the adjustments that these practices have to make takes time. That's why this demonstration was a 5-year demonstration. And it wasn't to say, was everything perfect at the end of it? It was, can we start to make those shifts and see some measurable improvement as we move forward in healthcare? And are people better off because of it? And I think we're starting to see that, yes, we've seen real significant improvements in people with diabetes, hypertension care. Like the trend is starting to move. And as you've heard, even though there's mixed results in terms of, do we like this process, the predictability of those payments for our healthcare system is key to making sure that that access is really available to Vermonters when they need it. Senator Lyons, I think you're.
Whoops. Thank you.
We all need a shirt. You're on
I
mute.
know. That's going to be the t-shirt of the year, probably the decade. Any other questions for Tom or Vicky on this? I think that this was a really good, sort of clear discussion and a presentation, and thank you for that. Any questions? All right, Senator Hardy.
Sure. It seems to me that this is still just a very few practices and a very few patients. And, you know, it's a tiny little sample size that you're doing these payments for. Is that right? You said 12 practices, and it's only like, overall, these payments are only like 2% of healthcare payments. Is that correct?
Yeah, there's about 12 practices, maybe 15 to 18,000 covered lives that were whose healthcare is now paid in this way. And but that being said, it is small in the relative scope of our health system costs, but it's an important step. We started with hospital fixed payments, kind of alongside it have been developing this program for independent primary care, learning a lot with some willing practices who are right there with us, rolling up their sleeves and trying to figure this out. And hopefully those learnings can evolve into other fixed payment evolutions that kind of slowly and iteratively take a larger bite out of the healthcare spend.
Yeah, so remember that the hospital primary care are already under a fixed payment system. So that increases the amount of primary care that are actually under a capitated payment. They just don't have the program that's available to the comprehensive payment reform for the independents, which adds in those additional investment opportunities. So if you look at the opportunities for independents versus their hospital counterparts, if we were to earn shared savings, the additional investment opportunity is about 49% greater than those at a hospital or an FQHC that are under the same model. So what we'd like to do is be able to see how we could take components of this and really expand it out to other primary care independents that are in it right now. But really, we designed this originally to support the needs of independent primary care physicians.
Okay, so the primary care practices that may be associated with a hospital, those are already under the capitated payments. This is just the independent. Okay, that's a distinction I didn't understand before. And even with that though, capitated payments are only 2% of the.
No, I think, Tom, they're less, but.
For programs that offer a fixed payment based on our network configuration, call it half of the total cost of care is coming to OneCare as a fixed payment, and half remains paid fee for service, either to other in OneCare network providers. It could be out of state providers too. Somebody goes to Mass General, that's going to pay fee for service. For programs that we haven't yet developed a fixed payment collaboratively with the payer, that's really the opportunities to get those other programs offering a fixed payment so that we can continue to grow the aggregate total cost of care that is now under a fixed payment or reform payment model.
Okay, so half of your payments, OneCare's payments, are the capitated payments, and half are still fee for service. Is that overall, though, the payments in our healthcare system statewide, what is the percent of capitated payments through OneCare overall?
I could take a stab at it, but I'd prefer if it's okay with you
Yeah,
to
I think-
actually look
I
at some
think it's
numbers and send it to
2%.
you
That's what
afterwards.
I think we heard in a presentation. So that, I guess this is sort of going to my comments previously. Robin has her hand up. She probably knows the answer.
Yes, we're gonna get, I knew she would.
We can clarify that when you come back to us, the 2%, because that's based on, I think, a chart that our staff uses to talk about total spending, total cost of care, and value-based payments through the ACO. I think one caution I would make about the fixed perspective payments is that all of the payments that go through the ACO have some risk component regardless of how they're paid. So the entire ACO program dollars are value-based payment. We focused on the fixed perspective payment for certain types of providers because we think that may move more quickly in the delivery system change that we as a state would like to see. But fixed perspective payments will not be appropriate for every provider type. And you can actually see that to some extent in the CPR program, because some primary care providers either are too small or don't want to have an EMR or don't want to deal with the quality metrics. And so those folks are not going to voluntarily sign up for this kind of program. So not to derail or speak out of turn, but just wanted to make those couple of points.
Okay,
No, this is helpful. Go ahead.
That's what I was referring to, was from your presentation. I was like, I know this stat from somewhere. So I guess this sort of leads to the point I made previously, is that because it's still so small and so incremental, which I understand it's a huge new initiative that you're making, Vermonters are not seeing this in their everyday interactions with our healthcare system. They do not understand this. I mean, I'm having a hard enough time to understand it, and I'm getting testimony from the experts in the state. They're not understanding that what is going on and where this is leading and how it's impacting their care and their access and their affordability. And I think that's the thing that's really difficult for us as public officials to stay behind this effort for so long when the impact on real Vermonters is so minimal. And yeah, that's
Invisible. It is. Yeah. The patient doesn't know, but if you're someone who needs to get to a designated agency and all of a sudden there's, or you need to get from the hospital to the step down facility of some type, whether it's PT or whatever, and all of a sudden it's the transition is smooth as silk, then you do see it. So
I was going to say that, Senator Lyons, thank you for saying that, is that, a lot of these things are meant to be seamless, right? Patients are just going to receive better care. They're going to get timelier access to that. And we don't need that to be looked at because of the ACO. The ACO is at its heart a collection of providers who are working together for the betterment of healthcare. We provide tools to support the providers in those endeavors, but what the patient should see at the end of the day is that they get to the skilled nursing facility and they didn't have to stay in the hospital for 3 days prior to. They can walk down the hallway and see a clinical psychologist the same day because the practice has somebody embedded. They get diabetic educator group visits that they didn't receive before. People aren't going to necessarily say that's because of the ACO, but it is because of the ACO and the structure and framework that's in place because of the ACO. So I hear what you're saying. And at the same time, we weren't meant to come in the middle of patients and their providers. we're here to support providers to provide better delivery.
And collect quality data.
Yeah.
Data. Okay, so questions? It's a heavy lift. Go ahead,
Yeah.
Senator Hooker.
Thank you, Senator Lyons. I'm thinking about the providers themselves and the fixed payments. I know give stability. Are the providers given the entire payment up front?
For
Every
all
month?
of our fixed payment models, there's a monthly fixed payment. So fourth Friday of the month is our pay week essentially, and that's when we pay hospitals or independent primary care participating in the CPR program.
Okay, so there was some concern that some of the funds were being held and not paid to the providers for an extended, until like the end of the year. I mean, how does that fit in, or where am I getting that mixed up with something else?
That's separate from this payment reform initiative, but it's related to our strategy to broaden financial accountability across the network so that more providers have a financial stake in the outcomes of the programs. And by that, I mean are accountable for cost, and that can also materialize in shared savings. To avoid the kind of specter of an invoice at the end of the year, we've developed a monthly transaction to pre-contribute to the result. And then if we have a favorable result, that's fully refunded with also some shared savings opportunity in the end. It's small relative to this CPR program model, but I believe that's what they would have been referring to.
Okay. And that's monthly that's done now?
That's also monthly. Some practices have elected to defer that to the end of the year and have chosen the invoice path. That's at their discretion.
Okay. Thanks.
Other questions? All right. Thank you for being available and coming in to talk about the independent primary care project. And I guess the other question, the last question, because we want to have the Green Mountain Care Board for a little bit. Are you seeing any interest, increased interest from primary care folks, the independents, in wanting to be part of the program?
Well, I can speak of past history. We've seen some really impressive growth over the last few years. I think the first 2 years as we were developing, we had a small but stable cohort. And then in 2019 and in or 2020 rather, and in 2021, added practices each year. And I hope that continues into the future. We're beginning our 2022 network recruitment process, and we'll have more information about added interest in a few months' time. But we've had such encouraging financial results that I hope to see more participate.
Okay. Thank you. Thank you both. This has been
Thank you.
helpful.
Welcome.
Thank you for the
Good.
opportunity. Thanks, Green
Sure.
Mountain Care Board, for letting us use some of your time.
Well, they're getting used to
Sure.
that. Robin, Sarah, and Elena are back. And Robin, some of the questions were regarding the number of attributed lives and the growth of the program. And so from your perspective, just a review, a quick sort of comments on some of the questions that you've heard.
Sure. And Elena, I don't know if you had specific information as well, so you should chime in as well. So I think, if you'd like, we can review that slide around the different components of value-based care compared to total spending, if that would be helpful. We have Elena pulled that up, so we could do that. The one point I would make related to that, in addition to what I already said, was that the total cost of care was by definition intentionally narrower than the actual total spending on healthcare services. And that was because when we are agreeing with the federal government to be accountable for a limit on spending for certain services, when we went into that, we knew that there were services we would want more of. For example, mental health and substance abuse. So mental health and substance abuse spending is not included in our growth trend in the total cost of care intentionally to allow for greater growth. Like, it's just illogical to put kind of a spending cap on services that you want to spend more on, right? So that's the other, I think, confounding piece with wherever this I don't think the 2% number is actually our number. That's a number somebody else has come up with using
No,
Yeah, go
I
ahead.
gave that number using, so that, I think it came from I'll just share the screen so we can all get clear on what we're talking about. So, and I put this out, I think, earlier this session to talk about kind of, we're talking about the high level picture and how much of the spend are we actually talking about. So it was a reference point. The value-based program, and this was based on, we have more up-to-date information, is actually 14%. So the ACO's value-based programs that Tom Boris was just talking about, the total cost of care, is about 14% of all of our spend. We talked about, of that, there's fixed prospective payments. Using that estimate, it was about less than 2%. So right now, those true fixed payments are really only Medicaid and the CPR program. So that's a subset of that total ACO program that we were talking about. But that's, so it really depends on the question, but this was just to kind of give a frame of reference. I think depending on the question that you're asking, there might be a different denominator. So if it's about uptake of FPP, we should really be looking at the fixed payments that providers are electing relative to the total opportunities they have to take on a fixed payment program. So not all of the payers, as we talked about, are offering these true fixed payment programs right now. So there wouldn't even be an option for providers to kind of participate in those. But that doesn't mean they can't be designed or offered in the future. So hopefully that helps clarify.
Questions for Elena? That does help clarify. Thank you.
Yeah, it does help clarify, except for, I mean, the 2% is if our goal is to move away from fee-for-service payments, 2% is only the portion that we have done so far.
No, the 14% is the amount that we have done so far, because the 14% includes risk on those fee-for-service payments. So from my perspective, because I think we want to move to fixed prospective payments for certain provider types. So another way to look at it would be the percentage. So for hospitals, which is the vast bulk of those fixed prospective payments, how much of the hospital payments to the hospitals are in fixed prospective payments? Because, for example, there will be some small primary care providers that it just won't make sense to do fixed prospective payments. So I think we have to be a little more nuanced. If we're going to use the number to think about like a metric to measure, then we have to be more nuanced about it.
So is it, sorry, Elena, is it fair to say that 14% of the possible universe of what is for payments is where we are then? Because I hear you that there are some kinds of services, some kinds of practices that will never make sense for them to do this for a variety of reasons. So go ahead.
I think to answer that question, it's really important. I think Robin's pointing to this as well, is to take the provider perspective. And so if you look at a hospital's total budget, which is what they have to work with, which is how they make their business decisions and choose, how to serve patients, we see, hospitals having 0 to 24-ish% of their budget being in a, and I don't, we use fixed prospective payment generally, so it could be Medicare and Medicaid. We'd have to dig into that further, but it is, we haven't hit that tipping point, but I think the provider lens is that lens that you have to think about. And as Robin mentioned, maybe not every provider is prepared to take on a fixed payment.
So Yeah, Elena or Sarah, did you have other comments on questions that you heard? I don't know that I necessarily did, but if Senator Lyons, there are specific areas you wanted us to focus on, please let us know and we can pivot to that.
No, I think sticking with the issue around primary care is very important, and but then also linking it with the hospital, because it is a hospital-based ACO, and many of the primary care clinics and providers are hospital-based. So in totality, if we were going to look at, I think, a review quickly of patient distribution, so Medicare, Medicaid patients, attributable lives currently, and then how many private payer lives are here, and then for me, the difficult part, and I think this is what Vicki also agreed with this, which was the self-insured market, where people are, so maybe link, I think the place we want to go is to link the cost, the increased cost associated with those different payers for patients who are either in or out of the fixed payment model. So if we're looking at private payers and we're looking at ESI, do we know how much our Vermonters are paying for those healthcare premiums? Some of them are benefits, we don't know that. So what do we know about the whole group of people who are not benefiting from this, I'll say benefiting from the model? Did I?
Yeah, so
I went
yeah,
along
yep.
too far probably, but go
No,
ahead.
no, that's okay. So I think, and Elena, I think you probably have some slides related to that would have attribution information and some of that
I did
stuff.
not pull that. Let me see what I have for today. I don't think
That's
I
not
can
on
find
today's.
latest TL
Well, certainly
information.
if we don't have it handy, we can pull that together for next week.
I'm-
But what
I'm
I would
just-
say,
So one of the enduring questions that sits around this table is, okay, all this stuff is great, but it's not helping people and they don't see it. So their premiums are going up, their copays are going up. How is this possibly helping people keep money in their pockets around healthcare? That's the question that we hear all the time. It is extremely frustrating to hear that question and not be able to have the simple answer. And I share that frustration with everyone. So
as
there's the
do I,
question.
because we
All
hear
right.
that as well at the Green Mountain Care Board when we're doing our regulatory process, right? So
Yep.
we share that frustration as well. I think that, what I can say is that in the self-insured market, which is largely Blue Cross does have a self-insured component in the ACO, and we can come back with the attribution numbers that spell that out. So we get a little bit of data from that piece. But if the employer has not agreed to provide the data to VCures, we don't know. We don't know their premium, we don't know their benefits, we don't know anything. So we have some data that we have that is submitted to VCures where we can look at that and understand how that population fits in. But for the most part, we don't know. In terms of, is this helping patients? I do think that is the key question that we need to continue to evaluate as we move forward with the model. And that we did hear at the board some results from the 2019 total cost of care results. But again, it's 2019 because of data issues in healthcare. So that's another, quite frankly, frustrating part in healthcare is the data lag. What I would say is I actually think that if the care coordination program is working well, it should be invisible to patients. we should be able to see results in terms of curbing costs and quality improvement, or at least flat, some more reasonable cost trend and quality improvements. But part of the point of moving utilization improvement to a provider organization from a payer organization was to put that closer to the patient and in the provider's hands. So I actually do agree with Vicki that if the ACO is working correctly, what the patient will see will be somewhat invisible to them. They will have better access than they would have had. But how do you measure that as a person, right? If you haven't
used the system.
Right, exactly. So I think that is part of the challenge with this kind of model, but I think we have to remember where we came from, which is we came from a system where utilization ups and downs were pushed by the payers, right? So they controlled utilization by prior authorization and by other controls put on providers. And so part of this effort is an attempt to shift away from that top-down, payer-down utilization management to a system where providers have enough information that the provider's office is able to work with their patients to manage the care. I think that we could, maybe what would be helpful would be to go over those 2019 results with you so that you can kind of see where are we with total cost of care, where are we with quality measurement, because that would give you a sense of where things are. Now, quite frankly, the other challenge is going to be COVID has just really come into the middle of the model, and we will lose 2020 and 2021 to COVID. Like, no one is expecting that during COVID, where utilization has dropped, that quality is going to improve, right? So that's going to be a confounder on evaluating this whole model, is that we know we've lost 1 year, we probably lost most of a second year. So, none of this is to alleviate your frustrations, but really to say I share your frustrations as the person who is trying to regulate an entity and to understand whether the model is working or not working, right? And so I think, we can certainly try to come back with some data and information to share with you where we think we're at. But I just want to be honest that, part of the challenge around this model is going to be 2020 and 2021. Elena, you look like you have something to say. Maybe not.
Well, I just want to note that I did bring kind of a summary of the performance to date, if that would be helpful. And then if you wanted to dig into it, we could come back in more detail.
I think if we can have it and get it up on our webpage, and and that would be helpful, because we're starting to run out of time, and I want to finish a little bit early this morning, so we can get to the floor at 11:30 in sort of composed manner. So do send that to us. And I think the other interesting issue is on rate setting. And so rates for insurance premiums, that definitely, and then the change in copays and so on and so forth, that happen within the private environment as compared with Medicaid. I hear the Medicaid complaints all the time, but they're far and few between. What I do hear are the complaints about my copays for my private insurance going up, and those rates and how.
Sure. So if you want to hear, so DVHA would be the exchange would be the appropriate place to come in to talk about. It's really the structure of the Affordable Care Act and the individual and small group market that drives those copay increases. And right. DVHA has a plan design group that they work with stakeholders to manage that and brings it to the board for approval. But they really would probably be the best person to talk to about the copay challenges. And certainly we can come back with some more information about rate increases and what that's been looking like in the individual, small group and large group market.
That would be good. And I know we have Diva coming in next week, and we'll put that on the agenda for them. So that's good.
Yeah, and there's
Yeah.
there's some good news if I don't know if they're coming in to talk about the ARPA premium tax credit changes, the federal changes, but there's some good news there in terms of bigger premium. Senator Cummings has heard some
I
of this.
think
in
that
her other
probably
committee.
that'll be dropping into finance. We will be
Mm.
interested in it. You're muted, Senator. Senator Cummings, you're muted.
I believe it will be on the floor Tuesday.
Oh,
We
great.
passed it out last Friday, went to rule, so it's on notice today.
Yeah, and I wasn't really speaking about that issue. I was really just speaking generally about how the premium tax credits are increasing, which will increase affordability for individuals.
Senator Hardy.
One quick note on that, what Senator Cummings just said, Robin, you had noted in our other committee that should that legislation move forward, that you might need more resources for actuarial services. So I don't know if Nolan's done a fiscal note, but
He has,
Yeah.
yeah, he's done a
did,
fiscal
okay.
note. Yeah.
okay, good. But more broadly, I mean, our conversation and what I keep repeating is that, we're getting toward the end of the session and we have this big global commitment waiver renewal process happening. We have these frustrations in this committee, but also out in the field with our constituents about healthcare costs and accessibility, et cetera. And we have potential opportunity with the feds, and you guys are moving along with lots of really good information about payment reform. So I guess what I would love to hear from you, and I'll ask this of pretty much everyone who comes into our committee, is like, what would you recommend we do in the off session? What would you recommend we do as our priorities for telling DIVA and others what our goals for the renewal of the global commitment is? And then to this earlier conversation we just had about services. I don't know if you heard our conversation about hearing aids and other things with DFR, but what are other services that we should consider getting more information about? Because DFR is doing a grant that will provide analysis of adding, coverage for various things. So that's what I would like to hear as we're sort of trying to move forward at the end of the session and set ourselves up for progress over the next 6 months and then hit the ground running next year.
So that is one of the reasons why you will be invited back in to testify. So I think we'll leave it at that. And again, you three have been extremely patient with us, and also extremely helpful, and we appreciate it greatly. So Elena, if you send along your slides to Nellie, she'll put them up on our webpage and we'll have access to those. I know you keep sending us really great stuff. And then we'll have you back in to help us move forward a little bit on S132, S120. Oh, great.
Thank you.
Thank you all. That's good.
These are great. Thank you so much. I've learned a ton from you, so thank you.
So what we'll
You're
do,
welcome.
it's been how many years have we been together, Robin?
Oh my God. Well, I started at the legislature in 2003.
Yep, since then. Okay. That's great. You'd think some of it would rub off and I'd learn something. Thank you.
Yeah, Jenny.
Anyway, let's call it a day, committee. I think we have a lot in front of us, and we will come back to these issues. To thank you for your attention, and I'll see you all